I look at what they have, and I would want that. I want to be that strong, dependent wife of, four, manly children, four men that she's raised. She's 4 foot so small and British and just so unique and just full of life. She's in her 80s and her house is way cleaner than mine, and she could run circles around me, and their vibrant history and their stories. I mean, I love that about them. The love that they have for each other, the standards that Beryl has for caring for her husband is so remarkable, and you respect that. And it's amazing that she gets up at 2 in the morning and she has to do what she has to do. And then she's still answering the door at 10 a.m. with the home health aide coming in, to help take care of Jim's personal needs. So I think that's what really stands out about them, is that their life story is just so colorful. Our top priority when patients come into the hospice house, our top priority period with hospice, is to try to manage their symptoms. You cannot worry about financial concerns or grieving issues if your pain's out of control or if your nausea is just uncontrollable. And so the top priority really is getting those pain and symptoms managed. And that's what we do here at the hospice house is, we try to fine-tune that medicine to get the symptoms managed. Once we're on that road, then we like to come in as social workers and see what kind of support they have in place, see what they're wanting, what they're expecting from us. Everybody has a different expectation. Beryl is a very socialite. That's how she's always been, and so she needs somebody to listen to her. I think that's very important. And my role is to be that listener, to kind of validate her feelings, and just give her an option to vent a little bit. Our patients and families, they're in this situation that they don't want to be in, and sometimes most of the time the families go back to their roles of going to work and taking care of this and taking care of that. And it's not that they forget that their loved one's sick, but their lives go back to normal, whereas Beryl, the primary caregiver, and the patient, Jim, it's all different. And so they can't call and be like, oh, I've been up all night, and oh, he won't stop calling my name, and because those family members, they don't understand. And so I like to be that listening ear where I call in and how's things going, and oh, he was up all night, oh, I bet that was rough for you, trying to have some compassion for what she's going through. Part of my role being a social worker is to validate those feelings and not say, oh, you shouldn't, not to try to correct them. Oh, you shouldn't tell him to not talk about those things, and you shouldn't be mad at him because he's bringing up all these bad memories. It's not him, it's the disease. You can't tell somebody how they should feel, but I know being a social worker, being in this field for over 10 years, that those emotions are real. And I know that it's probably the disease that's pushing this. It's not the patient. So it's important to be able to hear that and to be receptive to that. But then also kind of allow them a different way to look at it. With Beryl, she loves to talk. She really talks through her emotions. And then with the stories that she's told me in the past, I kind of reaffirmed to her some of those things. Before I got off the phone with her, I was like, what is that thing that your dad used to always tell you? And she's got this statement about, I think she was a Tyler or something, her maiden name. But her father used to tell her, hey, you're a Tyler, you buck up, you hold your shoulders and your back straight, and you can, and those little intimate stories that she shared really allow me to know how to approach her in conversation. You will see those opportunities or those times when it's appropriate to talk about the reality of the situation. As Jim was declining in a sense that he was sleeping more and he wasn't able to get out and drive Beryl around anymore, and he was a little bit more needy than what they had been used to, she started asking, what am I supposed to expect here? How's this going to look? And that's such a difficult question. How much time do I have? She wanted to know time frame wise. And that's so difficult to answer because everybody is different. There's some general signs and symptoms that we can talk to people about, and that I shared with Beryl. And that was that moment of, here's the truth. It's going to be hard. You're going to be exhausted. There's going to be times where he thinks his nights are his days, or he may become confused, or he may not want to eat anymore, or may not be able to eat as much. And we talk about those signs and symptoms and things to expect. Now, how much they take in and accept is, on them. But we try to find those opportune times when they're ready, when they're asking, to answer those questions. Well, it's never easy, but, I find that my compassion or my sensitivity, I used to think of it as a weakness. But now, and after years of working with patients that are ill and death and dying, it's a strength. It gives me the ability to get in there and put aside all the fluff and to be connected to that person emotionally, understand where they're coming from, or at least be attentive and aware, sensitive to that. A lot of times, the majority of my patients, I'd say maybe 90% of my patients, it's sad. Of course, I'm saddened by their decline, but there's a peace and a comfort in knowing that we are in there. We are providing that extra support, and we are helping them through this process. There's a comfort and a peace that I get, and I know my coworkers get, being able to help, and knowing that when it is their time and when they do pass on, that there's no longer suffering. We don't know what that next step's going to be, and everybody has a right to their own perspective, but we know there's no more suffering. We know that they were taking care of the best that they can, that they were, and that we did the best that we could to help.